Welcome, everyone. It's Angela Love-Zarenka with Lactation Education Resources. Thank you for joining us today for our topic and our special guest, Bryna Sampey. Nice to see everybody today. I'll hand it over to Nikisha Killings. Nikisha, hi.
Hello, that's me. All right. Sorry, I jumped out of our screen here for a second. I want to come back. All right. Hey, y'all. It's so good to be here. I am Nikisha Killings, Director of Equity, Inclusion, and Belonging for Lactation Education Resources, our gracious hosts who make this platform and discussion available today. I'm also a private practice IBCLC and perinatal equity strategist. And in that work, I do a lot of trying to prepare and equip those people who do birth work and those who train birth workers to offer culturally humble support and respectful communications. That's all that to say, I'm happy to be here today. And I do one other thing with my co-good troublemaker here, Nikki Hunter Greenway, who will tell you about herself.
Hey everyone, I am Nikki Hunter Greenaway, also known as Nurse Nikki. I'm a family nurse practitioner. I am a IBCOC in private practice in New Orleans and in Houston. I service both those areas. New Orleans, just for right now, we just moved to Houston, and I'm still trying to figure out my way because it is 18 times bigger than New Orleans. So I also do virtual stuff with my co-good troublemaker, Nikisha Killings, with Lactation Career Consultants, where we help folks demystify the path to becoming an IBCOC, especially for Black folks, Black and Brown folks, because we want to decrease some of those disparities. So today, we have a special guest with us today. We'll allow her to introduce herself.
Hi, I'm awful at introductions for myself, but I am a lactation consultant and IBCLC, and I'm also a doula. And I also do perinatal health activism, and so working in our area, most recently with Midwives, Others, and Mothers Alliance with Miss Shafia Monroe, trying to reduce police violence against pregnant people and lactating people. So across the spectrum. And I also am a mentor at IBCLC, and I have a private practice. So we see clients, and I have a couple of amazing lactation consultants who are graciously agreed to work with me and see our clients. And then we have some doulas too. And yeah, we're just trying to make the Northwest a better place to have baby. So yeah.
Love that. Love that. Welcome, Bryna. Thank you so much for being with us. All right, listen, we're going to get into it. And lots of people are here today to hear the topic, so we won't delay. If you're new here, though, we do check in first. We check in to see how each of us is doing, and we want to know how you are doing, audience, as well. Please talk with us in the chat. Let us know where you find yourselves today. How is your heart? What are you bringing into the space with you today, wherever you are? I will start to give my co-hosts here an opportunity to think through where they are, because it takes a minute sometimes to assess that. It's a weird space. I asked someone recently, is Mercury still in retrograde? Like, what is Mercury doing out there? I'm not well. I am not okay. All right. And I think I've said this for the last couple of episodes, and hopefully this is the end of this particular wave of whatever's happening. But it's just a real interesting space of not feeling really grounded in this moment and feeling a little bit tossed back and forth. And that may have to do with the needs of my community, the needs of my family, the needs of my work, all being demanding at once. But I'm a bit untethered in this moment, and I ask that you send me good vibes to correct that post haste. But the work is good, the family's good, everybody's good. It's just it's a lot in this moment. That's what I'm bringing to the space. Nikki or Bryna?
I'm good. I'm actually feeling really good. I just came back from the chiropractor, so I can move my body. Like, y'all, I'm acting like an owl over here, like moving my neck all the way around. I don't think y'all understand what that does. Like when you haven't been able, when you have restrictions, first when you have mental restrictions, it's already enough. But when you have physical restriction, you can't, like your child is talking to you and you like have to turn all the way around. It messes with your whole psyche. So I actually feel really good. I have no complaints. My anniversary is coming up this week, and I'm really excited about it because my partner planned something, which never happens. So I'm actually really good, y'all. I'm really good, and I'm gonna sprinkle some good stuff over to my co-good troublemaker, and then Bryna, if she needs some too.
Thank you. Speaking of Bryna, how are you?
Well, thank you. I will take all the good vibes I can get. Like a mixed bag, I guess. I'm currently I live on the West Coast, and I'm currently on the East Coast, visiting my girlfriend's family. So I'm in her aunt's house here now, and I'm meeting everybody for the first time, all the family and friends. So we're in New York for a few days visiting her family. She's from Long Island. And then we're going up to Massachusetts and then Maine for her best friend's wedding. So I like in 1 week, I get to meet all of the people important. So that's not stressful or no pressure. Yeah, but I'm, and then at the same time, I'm in the middle of an interesting and intense divorce. So with my kid's dad. So it's, there's good and there's bad, and there's like all of it is like, the world is teaching me, or life is teaching me, that like if you persevere and push through, you'll come out the other side. Whether that other side is better or not is not guaranteed, but I hope so. I'm thinking so.
Absolutely. Multiple people have messaged me, by the way, to let me know that Mercury is out of retrograde.
Lies.
Maybe there's residual. Maybe
I read a thing that Mercury's in Gatorade, so maybe that's where it went.
Something is not right. Okay.
Something's not right with the world.
If Mercury could please get its stuff together, that would be great.
Thank you.
Maybe the next thing is happening. Whatever it is, y'all. For sure.
Venus? Yeah, Venus. Maybe Venus is now running around.
I don't know. Mercury's in blue Gatorade. All right, I'm hearing. Yeah. Multiple people here are agreeing. Thank you, audience, for letting me know that things are out of whack for you as well. There's a shadow period for processing all we've learned during retrograde. We're in the shadow period. That's what it feels like. Thank you, whoever said that.
Thank
I'm
you.
in
Is
the
that
shadow
where we get
period.
the Oreo cookies after the blue Gatorade? Because that would be great.
Yes.
I would like shadow Oreos. Yeah.
Oh, is there shadow work I need to do, or will that just transition? Somebody tell me more about the shadow period. Anyway.
I think that's the Oreos. If you dip them into the milk. Yeah.
Okay. Well, there you go. Solution noted. I will be working that out as soon as we're done. All right. No further delay. We are going to jump into our topic because there's a lot to unpack here. But first, we're going to take a quick look back. I'll say this: Nikki and I very rarely revisit the same topic,
right?
And we've been doing this going on 2 years now. It feels, I think. And the only time when we've revisited the same topic over and over and over has been our first several shows that were on COVID for months, actually, because there was always new information to learn and things were changing so rapidly. Bless you. And then there is also, we do the How to Become an IBCLC quarterly, but we do that through a different lens every time. This topic, supporting 2SLGBTQIA plus communities, is one that we're revisiting for a number of reasons. Last year, we did this topic with the incomparable anthropologist, Black feminist anthropologist, Savannah Shange. We did it with her talking about words, terminology around supporting these communities and the value of it, and getting to the nitty gritty of what words make sense when and for whom and how. That, however, led to a whole lot of other stuff around supporting these communities left to be said. And so we want to make sure that we revisit to kind of talk about it from another vantage point, because much like in COVID, things change and evolve, and there's more to learn and more to discuss on these topics. And I know that's why you're here today. We have to do a throwback, though, to that particular episode. First of all, I was fangirling during the show. I don't know if you remember that, if y'all noticed that, but Savannah Shange is daughter of Ntozake Shange, who is an amazing poet and Black activist in the United States and the world over. And so it was a little intimidating to be in that presence, knowing your mama was hot stuff. but we soon learned Savannah was as well, and pulled no punches and shared with us truths that were really necessary to gather in that moment. And so you all have seen those that have seen the episode. For pre-work, we all went back and saw it, and we'll even drop a link to it. Nikki, I can't do that. Yeah, Nikki can. All right, drop a link to it in the chat so that you can reference it as well. It's available quickest probably on YouTube under LER's page, so that you can watch it back. But I want to real quickly ask everyone on the call what they remember getting from that, or something significant that they would bring back to this conversation. I hope I'm not catching you off guard. For me, it was when I talk about the communities that are referenced in that acronym, or in that, is it an acronym? That really doesn't spell anything. Anyway, in the letters, the communities that are referenced, I had often been referring to it as the LGBTQIA, community. And Savannah quickly corrected me that there are numerous communities represented within those letters. And so it's not okay to lump everyone together in that way, and to always speak about each of those communities separately and differently, and as having significant and important differences amongst themselves. And so it should always be the plural communities. That was one of many things I gathered from that conversation, and I shifted in the way I address it moving forward in my work from that point. Anything stood out to you too from that conversation? Words matter conversation that we had last time?
Yeah, go ahead.
Oh, go ahead. We've already talked about it.
I really love having the anthropology layer on top of also like a queer lens too, and talking and like listening to her talk about the intersectionalities of everything from like her unique vantage points from her, like the position of her research, and like also like her experience. Like I thought like what a neat axis, and it wasn't all like trauma porn, because that's like kind of what you get a lot when you talk about oppression and you talk about intersectionality and you talk about, it's like, well, like all of these like, and there's just like moments of just like right at the beginning, like kids are like around and just like needing medical attention from that stuffed animal. Like there's joy, like also in living this life, and it was just really nice to see a full and holistic representation of a whole person, not just like a piece of a community that people don't always get to see.
I agree. There was so much to unpack, and I think even still, y'all will see if you listen back. And Nikki and I will wholly admit that we've evolved a bit in the way that we approach these conversations, and so you can probably jump all the way to 20 minutes in to get to the middle of the discussion.
Sorry about that, guys.
There's a lot of introductions, but if you listen to it back to it a couple of times, I think each time you'll get something new and really interesting perspectives based in her work and the research she's clearly done, and her lived experiences. Nikki?
Yeah, I agree. I think one of the big gems for me, and as I know, Savannah is a friend of mine, so I get on the regular gems and checks. But for me was clinical versus cultural, and how we do have to make that distinction. And I think if we focus, we can focus on both and be inclusive, right? And I think we have to be very intentional in our practices to cherish and uphold and be respectful of the cultural aspects that are there, but also it's some moments of it, especially with myself, when I dive a little deeper into clinical stuff when I'm with families, where I will talk about, circumcision care or vulva care, things like, but focusing on that clinical piece of that body part and not necessarily the gender, because while we're not degendering anybody, gender is actually not that important when we're talking about the stuff that when I'm trying to provide care to you. It has nothing really to do with it at all. But we're still going to be respectful of the cultural aspects that it brings into your space.
I think that is so true. There's so much I think that we assume that we know, especially those of us who maybe have been engaged and already doing this type of work for a while. We think that we know a lot, and turns out we don't always have all the answers, right? And not that we think we know everything. of course, even if this is our lived experience, but to hear it from someone who's been doing the work and really digging into it, there's always something new to learn. And so I'm really thankful that we held space in that way and that we got that information. I tried to answer someone in the chat. I'm not sure if that worked out. I'm gonna let you know if it did. Someone's asking how to reach Savannah and follow her work. She is at Black Femme Anthro on Instagram. I know that much at least. And I'll share that if I get any more information on how to reach her. But thank you all. I thought we'd be remiss if we didn't start off by going back to that one and at least referencing it and making it available to everyone to watch it back so that you can have the opportunity yourself to learn about the language. Before we move on, there is a question on that topic, Bryna, that came up today. In Lactagenesis 2, if you all are on Facebook, if you're a lactation supporter already, you know that is the space where it often goes down. And so there was a question on Facebook this morning that I saw or was tagged in at some point about when we're talking about this region and supporting folks, what's an inclusive term? What's a clinically accurate and inclusive term to reference all this, right? And there's a bit of debate about it. And I don't know if there's one answer, but I mentioned that we would address it directly today as a part of our discussion. So can we start there?
Yeah,
What are your thoughts?
I'm glad you did. You know, I'm glad you brought that up because I was thinking about that when I saw it kind of going down this morning. I weighed in a little bit. As I'm an admin, so I really have to, but it's like I'm out of town and I'm jet lagged. I'm gonna go back to sleep. The more I spend time learning from my clients, a lot of my clients are in the queer community, which is my personal catch-all term for all of the letters. But not everybody identifies as queer, and so I need to make that clear. For some people, that's still a really harmful term. So I'd like to make sure that I hold space for that. And I do ask all of my clients how they identify both themselves in their reference to themselves, and that includes their anatomy as well as pronouns, as well as, you know, expression of gender, experience of gender and sexuality if it's relevant. Obviously, I don't ask questions that are personal and not relevant to my care of them. And when we talk about anatomy, I am a huge, actually I saw Carolina Ochoa mentioned health literacy, which is a huge important piece for me because health literacy is like one of my other like most important topics. And so when we're talking clinically and when we're talking professional to professional, I usually use mammary parenchyma or just parenchyma as a catch-all terminology for the whole shebang. If I'm speaking about the lactating or the endocrine, you know, the secreting bits. If I'm speaking about the structural bits, I'll say torso is just generally my go-to first terminology, torso, because we are also dealing with the intercostal nerves which go into the spine. We're not just dealing with like the pectoralis, chest, breast area. But I will use a mixture of terminology. Personally, I don't think there is a right answer, in the same way that there isn't one word that fits everybody for their own expression of anything, really. Like, we're all unique. So chest, breast, torso, mammary gland, parenchyma, depending on who you're talking with and like what you're using it for, the terminology is super dependent. That's why we have so many words, which I think is an important thing too. So sorry, very long answer.
No, I think that's beautiful. Nikki, do you want to weigh in?
Yeah, I would agree that there are a lot of terminology, and you use it based on who you're talking to. If I'm talking to another medical professional, I know they're going to know what parenchyma means. Then I'll use it with them, and that's how they automatically know. Like, you, me, and you, same. But you know, if I'm talking to one of my teen parents, I'm not going to use it. Like, they just found out what vulva meant. So, so again, I'm trying to infuse vulva into every conversation we talk about. But I do think that it's appropriate, you know, to have in your toolkit a plethora of terms. So it's not just like one term and you're using it all the time. You can get a feel of your environment and who you're working with. And again, individualized care. There's not one term that applies to every single dyad. There's not one or triad. or whatever the situation may be. See, so we can't even say diet all the time because it could be a triad. And so we have to make sure that we're providing individualized care. And in your marketing or whatever, you can put 2 or 3 terms in there, but in your care, you could have 8 terms. And that is what you pull from on any given visit and any given interaction. So I hope people keep that in mind, is that we're not asking you to throw away everything that you've learned in the past of all of the non-inclusive stuff we are, or anything that is biased we are. But just give yourself, fill up your toolkit. You may need a bigger toolkit now because the landscape has changed. Even though it's always been there, we're incorporating a lot of other things in there. So put those things in your toolkit, in your assessment tools and all that type of stuff.
Yeah, I don't know if there's any more I can add to this. I love this approach. I think, to your point, language is so rich that you have the opportunity to choose any number of terms that speak to your particular audience. I would say that to Bryna's point, the health literacy of your audience matters in terms of the terms that you use. It may well only work to say, I don't know, boobs, I don't know, whatever word. I don't do a lot of teenage care, but there's probably some words that they get that will resonate far more than talking about mammary glands, right? They're like, what? Interestingly enough, I've taught to elementary age kids though, and it really resonates with them that we are mammals and we have mammaries. That makes perfect sense to them. Like, oh, like whales. They get really excited about this. But something is lost kind of in the middle there, and so that's not a term I would use with my average parent as much. But yeah, I think that there's an opportunity to really get to know the audience to whom you are speaking, and to speak the language that makes the most sense for them. This isn't necessarily an opportunity to educate.
Well, that's such a good point. Yeah, no, can I jump in? I'm sorry.
Please.
I get so excited. I'm like, I mean, it really, yes, because I think a lot of people have like this passion and heart for education, right? And like you're like, oh, what you're saying is not actually right, or like whatever it is. And like especially when you're working in communities who have been disenfranchised, if you're working in a teen community, if you're working with a queer teen, if you're working with a queer teen who's been disenfranchised in multiple different ways, and you tell them that they're wrong, like their experience is wrong, even indirectly, you've lost them, right? And so like when you're talking with trans people who have been like disenfranchised at a rate of 86% across, in the United States, and globally it's much higher. It's like 93% from the numbers that we do have. And like, you're talking to people who have disengaged largely from the medical community completely because of trauma and pain and disenfranchisement. And on top of that, then like when they are coming to you because they have no other choice, which is usually when, we see engagement with care, you have just a little bit of time before you are also unsafe, right? And so like, if you're gonna waste it on like making sure somebody says areola instead of nipple, like it doesn't matter. And like it doesn't matter. Just use the words that they are asking and they're using and they're wanting you to use, because that's how you make someone feel safe. Like, we don't need to prove that we're smart. Like that's not what this is about.
Right. We don't need to prove that we're smart.
I mean,
they didn't come here for this. They didn't come here for this.
No, it's not a science class.
It's established. That's why they're here. They think you know what you're doing. Like you don't even, I love that. Thank you, everybody. I hope that piece has been helpful to those who are seeking it. And again, listen to that prior episode. We go way into a discussion around terminology, and we talk about that particular question as well. So I didn't want to take too much time today, but I wanted to make sure we touched on it. But the consensus is you have at your disposal so many options, and using what makes sense for your audience is the key. And it won't be universally accepted. Full stop. Not everybody will love it, if you will. Thank you. I want to honor the folks who chimed in the chat that they're having a difficult time. I see you, and we're with you, and we're holding each other up today together. All right. Now, today's topic. Bryna, I'm gonna let you take it away here in a minute because you are the expert here. I think you are probably no, absolutely more versed, more experienced at supporting families within this set of communities that we're talking about. This is me capturing all the letters, y'all. Queer communities, queer families, as you would. And so we want to make sure that we defer to your knowledge and expertise as you share with us today. Nikki and I never want to sit in the place of expert when we can have someone else more experienced to share with us and our audience today. But we also have something to contribute, and we will. But can we start with why? You taught me this as we were talking to plan today, Bryna, why the letters are not in the order that people are used to seeing them in for this particular talk today. We have referenced previously LGBTQIA 2S+, and today you might have seen on today's marketing for today's talk, it is listed as 2S LGBTQIA+. Can you tell us about that?
Yeah, and like when we were speaking, I even like mangled it too. My brain is so on autopilot sometimes with the alphabet soup, you know, the queer umbrella is like sometimes what I'll call it, and or the rainbow umbrella, depending on who I'm talking with. But yeah, the 2S. I have a good friend who I work in the mutual aid community with, who's Two-Spirit. And they were letting me know that there was this big push in a lot of communities to make sure that the experiences of the Indigenous rainbow umbrella folks is prioritized, because the Indigenous experience is something that is missed and is lost a lot, especially in queer conversations, because it's a lot safer for somebody who looks like me to be out and publicly out than it is for somebody who is Indigenous, because a lot of Indigenous communities are dealing with the echoes of colonization and the grappling of dealing with Christianity as a faith basis around, you know, their communities. My dad is his mom was Indigenous as Shahasapa, and to her death she was Catholic. And like, you know, was hardcore, and that's not the faith that is her tribe, that's not her ancestral faith. But in like so many, to deal with all of the things, that's where she turned. And so a lot of communities are dealing with the intersection of the oppression that Christianity and Catholicism tend to place on the queer community and the queer experience, as well as the colonization and the oppression from being in a space of marginalization and disenfranchisement and having your land and history stolen. So in all of that, the queer community really wants to make sure all of the queer communities, there's a lot of us, uplifting and prioritizing the experience, and that is often lost. So the 2S is going first as like a minor representation of all of that prioritization, if that makes sense.
It makes perfect sense. When you said it, I was like, yes, I get it. But if to have not heard that, I wasn't clear, and I was like, that is an interesting way that Bryna typed that out. Why did she, you know? So yeah.
And it's also it's important distinction too, that Two-Spirit and non-binary are different too. So people can be non-binary, which I'm a type, like my gender expression is gender fluid, which is a type of gender non-conforming, sort of in the non-binary sphere. And I would not say I'm Two-Spirit, even though I have a significant amount of Indigenous heritage, because I am not Two-Spirit, and I'm also not engaged with my father's and my family's tribe. And so there's a lot that gets wrapped up in that, and people kind of look at it from outside, kind of go, okay, the Two-Spirit, like non-binary, boy, girl, like that's okay, smoosh together. And like they're very different things. There's cultural versus clinical, almost, like, you know, it's not quite the same as cultural and clinical, but it's a very different thing. So if you are not, you know, engaged and you know, with a tribe, if you're not indigenous, then two-spirit is not something that is yours to claim. And so I want to make sure that that distinction is really, really clear.
I appreciate that. It really is distinct to Indigenous folks, and it's not a term that you'll see used outside of those communities to describe folks who both identify as with the masculine and the feminine, and non-binary in general. And so we had a direct question that said, what exactly is two-spirit? And so I think that we've captured that now. I hope that we have. If we have not, please make sure you chat again. I think that that's been captured. All right. Thank you. Thank you for putting that forward. This is literally the first place I've seen it or heard it discussed. And so I wanted to make sure we gave it space here today. Now, we want to make sure that we talk about supporting, and this could be very, very broad. Audience, let us know if you have specific questions, in fact, around supporting trans, non-binary, and polyamorous families. Any questions surrounding supporting communities in that particular section. Let us know how we can answer those questions for you today. Bryna, if you had anything that you could share with lactation supporters up and coming or established around supporting families, or anything that you want to raise while we have this time around supporting families in these particular areas, what might you share with us?
You know, I thought about like the things that like I wanted to like carry in my basket, to like the most important things that I wanted to put down in front of me today. And I think the thing that I deal with, there's two things that I deal with the most, especially when I'm working with trans and gender non-conforming clients. Is first is to not equate your experiences, even though I am gender non-conforming, right? So like I'm not going to equate my experiences, but I see this actually all the time from cisgender people, which means identifying as the gender that you were assigned at birth. As we assign people genders, which is different than your sex, like your physical sex characteristics. And people often are aligned with the gender they're assigned based on their sex characteristics, but that is not necessarily true for everybody. So when I say cisgender, that's what that means. And cisgender people typically try to equate experiences as a way of connecting. And I get it, and I understand why people do it. And, you know, I'm guilty of it myself in other places, and then until I like learn better or check myself. But when that happens, especially from a care provider, I check out, and I watch my families when my interns try to do it. It's like, even though we've had a conversation, everybody does it to like, oh, I want to connect with you, and this is how. And you just see the light shut down. You see that like sort of glaze, like, yeah, it's just like that. And then they're gone, and they don't have any interest in anything else that you have to say, because you are so far off the base from their own experience that you're not listening, you're not hearing, you're not making space for this person's experiences. You're trying to connect and you have an agenda, even if that agenda is not malintentioned or bad intentioned. And the other thing is to understand hormones of gender affirmation therapies. The terminology, there's so many. People can say HRT, which is hormone replacement therapy. They'll say gender affirmation therapy or GAT. There's a lot of different, that's not as important. Getting the wording right is like, we all mean hormones, you know, using hormones or the use of hormones, and understanding there's a million different ways to do that. There's a lot of different protocols, and they're changing all the time. Not everybody does them. Transition is a deeply unique and individualized experience, and sometimes it's expression through clothing or voice coaching or superficial changes. Sometimes there are surgical changes, sometimes there are hormonal changes, and sometimes there's none. And none of them makes someone more or less trans. All of them are individualized to the person. So there is no protocol. There's no one protocol for induction of lactation. There is no one. In fact, we don't even have the research. So like we couldn't anyway if we wanted to. And so all of it is incredibly individualized. So understanding and learning, taking it upon yourself to understand endocrinology at a deep level is going to be really important if you're going to be supporting people who are using hormones for gender affirmation, because you are needing to understand, oh, okay, so your testosterone level is at this, and if we want to see an increase in lactation production, we're going to need to see it at this, and that's what this hormone comes in. And everybody's levels are different. Some people's estrogen and testosterone track together, some people's track opposite, and you'll need to know what their chemistry is and does, and work closely with their endocrinology team. And if you're working with a queer endocrinology, like a queer focused endocrinology group, typically you have people that are very used to trying things and seeing how they go, you know, because the unfortunate reality is that being a person who is trans, who has to rely on hormone levels for the affirmation of the gender that we experience in our bodies, there's a lot of experimentation on all of us as it goes, because we don't have the level of scientific interest or research. Only in the last 10 years have we seen significant amount of research begin. So.
Thank you for that. I wonder, and I think I've been asking this question for years, in fact, is there a place for lactation supporters for whom this is important? For who want to grow in this area, who want to better support communities to come together and learn from one another and share their experiences with one another. Are you aware of a place that exists where there is a gathering of sorts? I'll let you think. I've not found one yet. I found and been thankful to be welcomed into groups where the families exist that want to be helped, and they share their experiences, but not necessarily where the supporters come together and share experiences to help one another come along in this.
Not as such, not as specifically around queer lactation support. There is a group, Outspoken Lactation in Private Practice, that grew up as like out of a crash boom, as they all do, or many do. And that's a great spot to start. I think that that's where I see those questions asked most commonly. And that's where I see the greatest concentration of queer lactation consultants, like those of us who are queer as well. And that's where I think one of the places I feel safer as a queer lactation consultant, you know, being more candid and you know, although in lactogenesis sometimes, depending on how much energy I have, I sometimes am a little more candid than others.
Thank you. That link has been dropped into the chat. Thank you so much for that.
Yeah. And if anyone else knows, that'd be great. I'm always listening.
Always. And yeah, I want to learn more about how to be a better supporter in that way. I hear you saying having a deep knowledge and familiarity with endocrinology and the endocrine system and how it's impacted by these treatments and protocols is imperative to understanding what the families are experiencing. And that is not a light thing. It could very well turn into your focus if you are serious about it. And I in that vein wonder where I guess the answer is in that group that you mentioned already, where those of us who want to be able to refer families to someone who's more knowledgeable, where we could be able to help direct families to, while it is outside of our scope or outside of our range at the moment, while we're learning and trying to get up to speed, right? How can I help this family get support? What would you say to that?
You know, I would say I really wish we had a list. I wish we had a secondary, like, special certification for this, and I wish we had a list of people who, you know, could prove that they give competent care, and that they're giving, you know, humble care, and they're being inclusive and not harmful, and also up to speed clinically. I have to go based on like word of mouth and like people I know, but they're not always available. So I kind of have to, like, you know, I have this little like list questionnaire that I send to other providers if I need to refer out. And like, have you worked with this? Have you done this? Have you done this? Are you familiar with this? What do you do in this situation? Like, I'm at like a little miniature job interview, like, and I don't want to be a jerk, but I also don't, I only want to send this, like, my client, my vulnerable families, to somebody that I can vouch for and I can make sure that I vetted. So yep. I'd rather be the jerk than the family have to have poor care. So
I hear you. Yeah. I'm copying into the chat. Sorry, not everyone can see the questions and the answers. I'm dropping those things into the chat. Let me know if you're able to see. There's a link to the new language recommendations that were put out some time ago that we've talked about in the last couple from the Academy of Breastfeeding Medicine. The inclusive language recommendations, we put those out into the chat now, and also the link to this particular group that we're referencing, the Outspoken Lactation Supporters, I think, group link on Facebook. We've dropped that into the chat. I have a question for you. Someone, first of all, is really excited. Nikki, you can jump in anytime, honey. I'm just I'm taking over here. I'm very excited and thankful because they never heard polyamory or supporting polyamorous families discussed in this type of setting. So very excited to be here and learn more about it today. And so there's a specific question on the floor I'd love to put forward. It says, can you talk a bit about balancing milk supply among partners if a family is co-nursing, particularly if there are multiple children in a polyamorous family, for example? Thoughts, either of you, any of us, jump in.
I mean, I have thoughts, but I want to give Nikki a chance too.
Oh, you're the expert. I would love to know also.
Expert is such a loaded term. I'm like, oh, I'm not. The more I learn, like the less I have quick answers for anything. I remember when I was like, 3 years into lactation, I was like, well, I know that. If only had just done this. Right. Okay. And now, now I don't know anything at all. I'm like, well, that depends on a lot. But yeah, this is something I've done actually quite a lot of. Some of my favorite families have been co-nursing families and families that live in community and poly communities. It's something that a lot of families won't tell you because it's not safe to be poly. In a lot of places, it's completely and totally illegal. CPS can get involved and they will take your children away for no reason other than the fact than you're poly. And so, I mean, you can go to jail. Like, there's a lot. There's like zoning and cohabitation laws specifically to set up to prevent poly families from all living together. So it's a very unsafe thing for people who are poly to be out, in addition to being queer, which often go together, but not always. And so when I have families that are feeling safe enough to let me know, I'm grateful for that. And I've done it a lot now. I've done support, and it's one of my favorites. So my very first poly family, everybody, this is Portland, right? So like everybody came trooping in barefoot and like all natural. And there are 3 lactating parents and 2 babies. One is a toddler almost, and one was brand new newborn. And that was exactly their question, was balancing milk supply, whether the toddler should nurse first to get a good letdown for the baby, or whether the baby should nurse first and the toddler can finish up, or how to kind of balance, and if they needed to make a schedule, or how to know who nursed who last. And all of those, there's no right answer to that. So what we did is we just kind of broke down the structure of the household. There was 2 houses next to each other. They were, going between 2 houses, and we figured out what their daily rhythm looked like. And then, we figured out how many intervals, each person could manage. So some people can do a 3-hour interval, no problem. Some people, that's too long and they'll start to lose their supply, right? So depending on a lot of things, hormone storage capacity, all the things that we know already is about lactation supporters, but this is then times 3 plus 2, right? So it's just the same things that we already do, but making sure that we're not applying our own mental framework to this family's day-to-day. Right? So like, that's the first question I ask anybody is like, what's 24 hours in your life like? Like, let's walk through it. I want to know every single thing from the moment you open your eyes till the moment you close your eyes. What does 24 hours look like? And I want to see what that is, because if I'm going to give you a plan, I could give you the perfect care plan, but if it's not going to fit into your life and if it's not sustainable, you're not going to do it. And then you're just going to feel like garbage and then be like, oh, I saw lactation consultants, they didn't help. Like, yeah, of course not. Because I asked you to jump through 6 hoops when you're already juggling 3 flaming plates. Like, so like, what? No, of course not. And so it really is the same, but a little different. So it's just about listening and understanding, again, basics of lactation, and then some. So it's a little bit juggling, but I think these families are super willing and interested because that's why they're in your office. And also don't just have 2 chairs. I learned, you know,
Yeah.
sometimes
Something that simple.
couch,
Something that
that
simple.
couch came in handy. Yeah, because we needed the whole couch and I sat on the floor, which is great because I love sitting on the floor anyway.
Yeah,
But
I
like,
sit on the floor
yeah,
every visit. I'm on the floor.
I had one family that were like, it's actually like really offensive to us if you sit on the floor. Like
Oh.
I was like, I'm so like, thank you. I'm so sorry.
Mhm.
Yeah, no, I'll sit on the chair. Absolutely. Sorry.
I love this approach. Thank you for giving me that. That's something I'm putting in my toolkit now. Tell me what 24 hours in your life looks
Yeah,
like.
that's
What's
helpful.
been my go-to, some of you have heard me reference this before, has been to listen, talk to them in the care plan phase, give them some instructions and then say, tell me what you heard. Tell me what that sounds like to you. And then when they tell me that back, I start to get clues about it's not at all what I said. That they heard something else, or they're fitting it into their life differently than I imagined, kind of thing. But this feels like I can lead with it, lead by being more informed about what life looks like in their shoes or from their perspective. And so that's really, really genius, I think. We have a note from the audience saying, and not asking intrusive questions just because you have a query
Right.
in who is sleeping with who.
Yeah,
Is why.
exactly. Because that's none of my business. That's none of my business. It shouldn't go on anybody's chart. Shouldn't even come out your mouth.
How are y'all? Nope, not important. Not important.
Not
It doesn't even.
One thing
I
I
care
was
how curious you are. Like it's like, yeah. You know, I had a client that said they were working with a different lactation consultant who is in our area and who's great. And they were like, yeah, no, she was super excited to help us, but she was so excited that I felt like a zoo animal. So I needed another queer because I just couldn't. Like she was like so enthusiastic. Oh, you know, and like oh, so like you know, it's
don't overdo
no,
it. Like just be
yeah.
normal. Just be normal
Mhm.
because this is a normal type of family. I have encountered a couple polyamorous families, and one of the things I focused on, and please correct me if I didn't do this correctly, but I focused on the recovering parents first, the postpartum parent, and I wanted to center their recovery. So I wanted that uterus to get back tight, and so I said that is the primary breastfeeder, like the first feeding, baby comes to this person, and then at nighttime, if y'all could help with those feedings while we center this person because they had a C-section, and I wanted them to get rest and things like that. But during the day, while they're up, let's center recovery because I really want to focus on that uterus getting back to where it needs to be and all that type of stuff. And then help out wherever it needs to be helped, like who's next? Who's next? I've nursed, or things like that. So focusing, centering the recovering parents' needs first. And then as far as what breastfeeding does for the postpartum parent, let's center that first. And then other folks can pick up when that parent needs rest. And then we protect the supply during those rest periods of that postpartum parent, if that makes sense.
Yeah, I mean, I think if that's the goal, like that's great. I think if the birthing parent, the person who gave birth, wants to be the primary breastfeeder or chest feeder,
Right.
like
Exactly.
great. But I think that to your point, like, yeah, the uterus needs to recover. This person needs to recover. They had surgery. They need to recover. So like, there's like a lot of other things going on in there, and you're not only focusing on that clinically, but you're also offering their partners or their metamors, which means the partner of your other partner, the opportunity to better support this person and in their transformation too. And like, what a great gift you gave to that whole family. Because like partners are always like, what can I do? Right? Like, this is a lot. It's like, it's like if you can be like, yeah, here's how you can be a superhero right now. Great. That's awesome too. So I love that approach.
Me too. That feels really good to me. And thank you for sharing that. And of course, there may be some scenarios wherein there is no particular birthing parent. However, we have this, multiple parents for whom we need to share the responsibilities of nursing baby. I love that. I wonder if, and there's another question, but my own question based on my own experiences supporting these families is that I often end up stepping into the role either of advocate or coaching them through how to get better care from other providers. Some things you could say, don't say that part, you know, to help them along the way to get better care. I wonder if that is a common experience. Bryna, do you find yourself stepping into shoes of advocacy often in supporting families? Yeah.
Yeah, all the time. Yes. One of the cool things I like is giving them secret phrases to say, you know, like there's one that went around the internet a while ago that as a doula I've been using a long time. Is like, oh, can you document your refusal to follow up on this? Can you go ahead and document your refusal to do this thing that I've requested? And it's an important one, and that's really important in people's care, because a lot of the time, like when we ask, I'm like, I'd like to check in on your thyroid hormones, because that's important. Like those thyroid hormones have a significant impact on this whole process, and I want to look at your cortisol hormones, which can change with gender affirmation therapy, and I want to look at and see what's going on here. And you know, I'm concerned, you know, about your adrenal glands or something, you know, whatever's happening. And a lot of providers are like, nah, we just looked at your thyroid 6 months ago, you're fine. And it's like, okay, can you go ahead and document your refusal to follow up on that then? And that's been like a really, I'm glad that went around and was viral, but like that kind of thing, those secret phrases. Is there any reason why we can't wait on this blah blah blah, that this intervention that we're not feeling right now or we're not decided on? Is there, like, that's another doula phrase. So like my doula work has really helped in that advocacy, but that happens all the time. Yeah.
I wonder, Nikki, as a nurse practitioner who can call for some of these labs and prescribe, and how does that land? How does it land on the receiving end there?
First of all, I wouldn't say that. But I do tell you, like, if you have insurance, I'm like, well, if we were to pick and choose, let me tell you the cost of all of these things, and which one is you think most significant to you right now, and then we can map this out. But it doesn't land very well. And even I myself have these issues. I'm like, oh, you're just going to do a TSH? How about we do a T3 and T4? And they're like, I don't think so. And I was like, okay, but I know that that's actually what needs to be done, because you still have a normal TSH and have a jacked up T4.
Yes.
And you can feel really out of wit. So it doesn't land well. And I think one thing we have to, and I was talking to someone else about this, is that we have to understand the consumer and the service provider relationship. You are the consumer. You are the consumer, and you just asked somebody to do their job and to provide a service, and they refuse. So I need documentation that has happened, because if something were to go awry, then you have that documentation. And there's a lot of pushback because folks think they are the experts, the absolute 100% know-all be-all, and that is not the case, because if they were, then there would be more inclusive care from the jump, right? So it doesn't land well, because you're challenging someone, and no one likes to be challenged in their space. But what people don't understand is that challenges make us better providers.
Yeah. And if they're not willing, then there may be an opportunity there to seek out better care, which I know is a privileged response. Yes. However, not everyone has options. Thank you for that. I appreciate you sharing how some of your colleagues may receive that. We know that to be the case, but we appreciate you sharing that with us. Questions that are on the floor still. First, again, people are really happy that we're talking about polyfamilies. Thank you, audience, for letting us know that. Someone says, how does one navigate care history questions? I wouldn't want to pry, but sometimes the information is incomplete. For this, I will reference you to our previous episode again, because I think we discussed in there that a lot of the things we're asking about history of the parent or the baby are not necessary to know. They really aren't. And that I challenge each of us to really take a close look and be honest with ourselves about what we need to know from the folks that we're taking care of in order to provide them optimal care. In the episode, Savannah talks about, if you're worried about, for example, I I put forward circumcision impacting baby's ability to nurse. Then you say on your form, does the baby with the penis has the baby with a penis had it adjusted or whatever, and that's it. Ask the question that you want to know the answer to. You don't necessarily need to ask every single ask the question that you need to know the answer to. You don't necessarily need to ask all the questions in the world to get a clear image of what's happening. Anybody else have thoughts on history taking and what you gather?
To Bryna's point earlier, when she was talking about having some knowledge of endocrine and hormones and things like that, asking the questions of, are you taking any medications, or were you previously taking any medications prior to becoming pregnant, is a very important question. Some people skip over that and they're like, vitamins. No, let me dig a little bit deeper. And it's not getting in your business, but it's getting in your business. I need to know what medication, because it dictates my care. That you taking a medication, something as simple as a blood pressure medicine, is going to change the type of care that I give you. And I really need to know that. But asking someone, have they changed their gender, or like, what gender were you assigned at birth, or, like all those things. Like, example, on my intake forms from an EMR that I am using, it has, what gender were you assigned at birth on there. And a client who is actually a cis woman was offended by that question. She said, why are you asking me this question? So it's not actually an important question, to be honest, because it's not going to dictate the type of care that I give you at all. What I want to know is your pronouns, but that other stuff, it doesn't really affect me. Like, I'm not going to give you a different blood pressure pill based on that answer. So.
Well, and like, I have that question on my EMR too. It's like in there, and I'm like, well, I made it so it's optional to answer. I have a bunch of questions that were like required. I was like, why are these required? I don't need to know.
Right.
Like, I don't care. If you want to tell me, great. Well, I had this one client who got exasperated with my questionnaire and like just started answering like nonsense answers, and I saw like that all the answers as they came in, and I was. I know you're frustrated, but like the ones that are required are the ones I really do need. I don't care what you do with the other ones, but please, like, and the way that I've done it is I follow the trail. So like circumcision, for example, like, why do I want to know about circumcision? Well, sometimes it interrupts, feeding and nursing and like latching and whatever. And like, okay, but like, does that follow that any surgery does that? Like any baby, like infant trauma does that? Any intubation, anything? So I just say, is there any history of surgery or hospitalization or, medical intervention in your baby's life between birth and now? Because that's the same thing that I don't need to ask in that loaded circumcision question, because I don't want them to feel like I feel any kind of way about circumcision or about gender or about transition or about anything, because they may not be ready to let anybody know that they're trans. They may not feel safe. So they may not want me to say that out loud, in the care plan, even sideways, so that their partner, who they may not be safe out with, that isn't going to know. So like, there's a lot of things that we can find out, but you just follow the trail to like, why would this impact care? Like you're saying, it's like, do I need this for blood pressure medication? No, like, doesn't matter. That doesn't change.
Yeah. So go through your intake forms, go through your care plans, and look at that, look how it's worded, and see, like, do I actually need this? Because you may have gotten it from someone else and you've adopted someone else's care plan or intake form, and just go through and see, how it's worded. Some folks are still walking around with intake forms that say mom's name, dad's name, and things like that. I'm like, first of all, why we need all these names?
I said occupation as well, and I was like, why do I?
Right. Right.
You know what? I do like
level
that
of education. I'm like, what does that?
Oh, I don't like that one.
Anything?
I do like the occupation question though, because I tailor my explanations based on occupation. So I'm like, okay, you're an engineer, so let's try. I'm going to talk this way because I've learned that engineers like these kinds of analogies versus like, oh, you're an artist. Okay, so like, it's like this.
I got you. So that's for your own.
Let me draw you a picture.
Yeah, that's cool. All right, yeah. We are already at our time here, so I'll have to wrap it up here. We didn't even get into Bryna want to talk sex, and we need to get into. We'll have to have you back to talk sex.
Listen, I was so excited to talk to you both because you both have like this amazing knowledge. Like I tuned into like a safe sex, like the lactation after dark. God, that was so good. I was like bugging you in the chat. I'm sorry.
It's okay.
But you know, that's like the idea of safer sex with like and harm reduction as applied to poly is just like something that's just like totally glossed over. So at some point, I would just really love to cover that.
We should.
But I talked too much. I'm sorry.
No,
No,
we have to have another after dark.
we'll have another after dark. We promised that we would speak to the audience's questions, and so that oftentimes takes us off our path, and so that's why we try to keep it as general as possible. And they are thanking us and saying that we did speak to their needs, so we appreciate you all for being here. And there's always more to come with Nikki and Nikki. Thank you, Bryna, for being with us, for sharing your expertise. And I don't like that word, for sharing your truth and your experience with us.
Yes.
We are grateful to you. Thank you.
Thank you.
If y'all are going to be around in a couple of weeks, we'll be back. We just have a couple more Nikki and Nikki's for this year, but the next one, our second to last of the year, is on November 3rd. We will be here recognizing Native American and Native Alaskan Heritage Month with special guest, one of our faves, Jaysha Lyons Echo Hawk. Yeah, she'll be coming to break it down like only Jaysha can. All right? Jaysha can. Talking about what it means to be a true ally, and talking about the Milk Medicine Collective and words matter. Again, changing the language and the narrative around providing lactation support to families. All right. Someone sharing. Oh, do we have resources in Ontario, Canada? All right. I for queer trans families, you have something?
Yes. Trevor Kirchanov is in Manitoba, not super close. And can you hear me okay? My AirPods just died.
Yeah.
And Trevor wrote Where's the Mother? He's a La Leche League leader. He's trans and he chest fed his daughter Piper. He's fantastic. And he's got a lot of resources. But that book
Trevor, the book again is
called Where's the Mother?
And Trevor's blog is milkjunkies.net. I believe it's still up. I believe at the very least you can find Trevor through.
I don't know these posting, but I could reach out and get back to you.
Yeah, but hunting down those two things, you will find Trevor in the wonderful knowledge that Trevor has put out into the world. So hopefully that is helpful to you. We're out of time. We got no more. Thank y'all so much. We appreciate you for being here. We will see you next time. Stay safe, stay sanitized, and the optional one, stay sane. Yeah. Take care, y'all.
Bye, everyone.
Bye.